Hello everyone, and welcome to today's webinar, Patient Engagement, the Key to Care Transformation. I'm Carolyn Wayne Kong, Program Officer for Healthcare and Coverage at Blue Shield of California Foundation. Before we get started today, I want to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout the webinar. If you would like to ask a question during the course of the presentation, please go ahead and do so in the question window on your screen. We will do our best to address those questions during the Q&A session at the end of our time together. Also, just a reminder that today's presentation is being recorded and will be archived on the Foundation's website. Please tell your colleagues who are unable to attend so that they can still benefit from the presentation and the discussion. So joining me today are several leaders and advocates who, like all of you, are committed to ensuring healthcare is accessible, effective, and affordable to all, particularly the underserved populations in California. As you listen to these speakers today, it's important to remember that how we engage both our staff and our patients is more important today than ever. Before we hear their insights, I'd like to give everyone a brief refresher on the Foundation's work around patient engagement. That will serve as a contextual backdrop for today's speakers. As you know, the healthcare landscape has been rapidly evolving for quite some time, even before the Affordable Care Act, which further accelerated the pace of change. To ensure that the care delivered to the underserved people of California has kept up with these changes and remains built around patient needs, Blue Shield of California Foundation sought to understand the primary drivers of patient preferences through a series of annual surveys. The findings from these surveys were shared with safety net providers and more broadly through our website and publications. In January 2015, we released the culminating report of our findings, delivering on a promise, advances and opportunities in healthcare for low-income Californians. We found that community health centers and public clinics have come pretty far in delivering care that patients value. For example, in 2014, more than half of patients believed their care was either excellent or very good. That's 5 percentage points increase from 2011. And during that same time period, there were other areas of improvement. For example, more people felt more welcomed in their clinics, more people liked the ability to make same-day appointments, and more patients were highly satisfied with their ability to see the same provider. This research has been particularly helpful in giving us insights on our patients' preferences regarding how they want to interact with their care teams and vice versa. So over the past year, we took the results released in 2015 and developed reference materials for you all to utilize when you're designing your clinic's patient experience with an eye specifically towards patient engagement. 2 items that are available to you are the issue brief, Improving the Safety Net Patient Experience, 10 Things Health Centers Can Do, and its companion infographic, The Path to Patient Engagement. These 2 pieces summarize recommendations based on our findings from our surveys, and they fall into 5 categories. First, obtaining staff buy-in at all levels is important because ensuring staff ability to interact with patients in a culturally competent manner is critical at all levels to a positive patient experience. Next, enhancing the ability to communicate will make it easier for staff to effectively connect with patients, allowing patients to feel more comfortable to share their medical concerns. Third, implementing new care models that are team-based fosters a sense of connectedness between patients and your entire care facility, which leads to increased patient satisfaction. Fourth, helping patients take an active role in their care leads them to feel more involved and satisfied with their role in healthcare decision-making. And lastly, using mobile and web technologies can help providers build engagement with their patients and improve the patient experience. The recommendations outlined in the issue brief and infographic are intended to help you be more competitive in this evolving healthcare landscape by taking a patient-centered approach. Patients who feel a personal connection with their caregivers are more informed, engaged, and satisfied with their care, and they're more loyal to their care facilities. In spotlighting these 2 pieces of material, I wanted to demonstrate the Foundation's commitment to helping you improve patient engagement, which is all part of driving patient satisfaction and overall higher quality care. We know that everyone is working hard to implement changes in your organizations, and we believe that patient engagement is a fundamental part of this care transformation work. So with that, I'd like to turn it over to our first speaker, Giovanna Giuliani. Giovanna is the Executive Director at the California Healthcare Safety Net Institute, or SNI. We've asked Giovanna to join us today because SNI's goal and vision are very similar to the Foundation's. They work with public healthcare systems to ensure that you are all recognized leaders in delivering and transforming healthcare practices that enable individuals and families, particularly those in diverse and underserved communities, to enjoy optimal health. Giovanna can also answer questions you may have on how patient engagement fits into some of the current care transformation efforts, such as PCMH and PRIME. SNI helps spread innovative practices amongst California's public healthcare system to ensure more people, especially those most affected by health disparities, receive effective, efficient, and respectful health care regardless of their ability to pay. So with that, Giovanna, over to you.
Thank you. Great, thank you. So as Carolyn mentioned, the Safety Net Institute represents California's public healthcare systems, and we are a partner organization of the California Association of Public Hospitals. And SNI really focuses on the programmatic and performance improvement side of California's public healthcare systems. And what I wanted to do today, I just have one slide. It's a somewhat busy slide that you see in front of you now. But I wanted to use this to ground the patient engagement efforts within our overall vision and overall care delivery transformation efforts, as Carolyn mentioned. When you look at this slide, it's intended to capture SNI's approach and framework to waiver implementation and to delivery system reform overall. And when SNI considers how to support its members in waiver success and in meeting its own strategic initiatives, we recognize that we're all working towards our public healthcare system 2020 vision that you see at the top. And in order to reach that, the waiver, the Medi-Cal 1115 waiver, is a key piece of it, not all of it, but is a key piece of it. And the orange rectangles that you see are really the types of support that we provide to our members for those specific waiver programs, for PRIME, for whole person care, for the global payment program. And at the same time, we know we need to provide support to our members around broader system delivery transformation efforts. And those are the focus areas that you see going across the bottom. And today what I wanted to do is just touch on 3 areas, or 3 buckets, if you will, of patient engagement that we see as really key to these transformation efforts and that we see our members undertaking. The first is involving patients in the design of quality improvement work. And when we kind of get a sense of what our members are doing on the ground, we see many of them engaging patients in patient advisory councils. And you'll hear more about that coming up. We see our members involving them in quality improvement or lean Kaizen events. So having the member voice present right at the time of design. And that's critical for really any of these efforts, critical certainly for thinking about quality improvement efforts for PRIME and for ambulatory care redesign. We also see our members doing ethnographic research, if you will, about what's the patient perspective and how are they experiencing care transitions? How are they experiencing, touching multiple systems in counties as part of the whole person care pilot? So understanding that perspective and how that can be improved, how those care transitions can be improved, you don't really know the patient perspective until you ask them. So doing patient interviews and kind of following the patient course. The second area I wanted to touch on was really getting real-time feedback from patients. So the first is involving them upfront in design so that you can really get to a better design more quickly, one that really meets their needs and saves you time down the road. The second piece I wanted to touch on is getting feedback on a rapid cycle basis to adapt what you're doing. As you're rolling out, PDSAs or rolling out small tests of change for any of these programs, for PRIME, for PCMH, for team-based care, you really need to, you can't wait 6 months for data to come in to tell you how you're doing. you need to get real-time feedback from patients in other ways, but especially from patients, to understand if what you're doing is having an impact. So if you're trying to do a proactive office encounter or trying to get colorectal cancer screening gaps closed, asking members why they didn't come in for their colorectal cancer or send in their test results or pick up their test, asking them what the barriers are is really critical to being able to close those gaps. So getting real-time feedback about things that you're trying to get them to do to close their gaps and why it did or did not work is really important in terms of your adapting what you're trying. Gathering real-time patient experience scores in the office is also another example of what we've seen. So not waiting for a CG CAP survey to go out, but getting feedback on a per visit basis using iPads, for example, really allows you to adapt more quickly. And then the third area I wanted to touch on is engaging patients in their own care, both in self-care and just being more empowered to seek out care and access care. You know, there's certainly a lot of interventions to improve self-management. There's motivational interviewing, there's self-management coaching that can impact, you know, Prime, can impact whole person care, can impact global payment program. And those are really critical to closing care gaps and to improving diabetes control, to improving hypertension control. We also see technology being used as part of engaging patients in their care, whether it's through texting platforms or encouraging them to use patient portals. Similarly, we really see systems providing more convenient access. That's really important, and you'll hear more about this later, but really important in terms of offering them access that's in a more patient-centered environment at more patient-centered times, after hours, or phone visits, for example, that allow people to work around their schedule in order to access care. And those are really critical as you think about the global payment program in particular. We have a population that perhaps had been previously uninsured and accustomed to accessing the healthcare system through either emergency departments or urgent care, creating systems and creating engagement strategies that educate them and offer patient-centered approaches that allow them to move towards more preventive care over time. So I will go ahead and stop there, and you'll hear some of these examples blown out more as you hear from some of the public healthcare systems who are talking more in depth about these.
Great, thank you, Giovanna. So I wanted to take a minute and introduce our other speakers who you'll be hearing from. Nia Johar is a project coordinator at the San Mateo Medical Center, and Nia will be talking to us about transforming care teams. Lucia Angel is a patient experience lead for care experience at the San Francisco Health Network in the primary care area. And Lucia will be talking to us about patient advisory councils and the work that they've been doing in building capacity with patient advisors. And then Dr. Shunling Sang is Associate Medical Director and Vice Chair at the Department of Family Medicine at Riverside University Health System in the Medical Center. Dr. Sang will be talking to us about a transformation effort that they've done around telephone visits. Also, before I hand things over, just a quick reminder that if you have questions, please go ahead and type them into the question window at any time. We'll do our best to answer them during the Q&A section at the end of the webinar. So with that, I'll turn it over to Nia.
Hi, thank you. And just like she said, we'll be talking about care teams, and I'm the Patient-Centered Medical Home Coordinator at San Mateo Medical Center. So here at San Mateo, we've begun our care team transformation to line up with our patient-centered driven focus. Care teams will allow our patients to be more involved in their care and overall improve their experience. We can define a care team as a structure around how clinic teams work together to effectively and efficiently take care of a panel of their patients. So why transform in the first place? We decided to transform care teams for three main reasons. First, we took a look at the primary care trends at San Mateo Medical Center that are also true across the U.S. There's a major shortage of primary care physicians, but there are also an increase in patient demand for primary care. Next is the shift from physician-centered care to patient-centered care. This allows the coordinating of treatments, tests, and prescriptions across providers in multiple healthcare settings. Along with the population health on the rise, the focus has been prominent on preventative care. And lastly, the changing in payment structure. During the summer of 2015, San Mateo Medical Center was faced with an influx of 20,000 new adult patients through the Medi-Cal expansion. This growth shifted our fee-for-service model, which was based in the volume of services, to capitation and value-based payment. So with this change in payment structure and increase of patients, we needed to transform the way that we provide care in a more patient-centered and sustainable way. Our planning process began with a 3P, which stands for product, process, and plant. We had a team of 15 frontline staff members representing from several of our clinic sites, and they all ranged from providers to RNs and clinic staff. Our first steps were to review the roles and responsibilities of each position in a care team model. We looked at what clinics were doing currently and then created a set of roles and responsibilities around what was said. What we found was that there was a lot of overlap and it wasn't clear whose responsibilities were whose. We also found that there was a lot of working below scope. So for example, providers used a lot of their time to do a lot of administrative work. With this information, we then created ratios revolving around a care team's panel size, shown in this chart right here. We have an example of a care team with a panel of 1,300 patients, and here is the amount of FTEs of each staff member must hold in order to have a complete care team. And lastly, we went ahead and chose a set of in-reach and outreach activities to help us plan and manage care. For implementation, our strategy started with designing an improvement event with staff and patient improvement partners. So these patients that were involved were selected from the medical center's Patient Advisory Council. They participated in all activities and were able to give us a patient's perspective. When we then went ahead and educated the staff on patient-centered medical homes building blocks that are the foundation for the care team's transformation. This was in an attempt to get everybody on board. So we focused on engaging leadership by doing different activities at monthly leadership meetings, like creating elevator speeches for team-based care. And these activities were used for leaders to be able to take back everything that they've learned and educate the rest of their staff. Then we were able to go ahead and train and validate the pilot staff on the operator standard work that was created during the improvement event. And for spread, we are actually still spreading our care team model to several sites. We're looking at the operator standard work and gauging where each clinic stands. Our pilot site is serving as the overall model for our standard care team for our other clinics, but in order for each clinic to meet their own needs, they may need to tweak or PDSA the pilot's model to to fit what they need as in size and etc. But there are certain expectations that can't be changed within each model. So to be successful in the transformation, we believe that you definitely need your champions, change agents, and natural leaders to lead the entire team, as well as a good communication plan, and to be able to try different strategies to get people on board. But overall, we're changing mentalities from cowboy to pitch crew. Instead of the idea that the provider is doing it all, with care teams, we're able to pitch in to help the patient receive the best experience possible. Our biggest challenges consisted of medical homes all currently having their own flavor of care teams. So everybody is doing it currently, but not exactly by our standardized measures. The entire transformation has been seen as a project and not really a culture shift. So in order to make it sustainable, we really need to push this mentality that this is here to stay. We have clinics of a bunch of different sizes, and we have been challenged to find a way to make this model fit with some of our smaller sites. But of course, with everything new, there's always resistance to change. This has definitely gotten better over time, but the best advice we can give is to give direct reasons to why this benefits your staff and what's really in it for them. So altogether, our care team transformation has the patient's best interest in mind. The goal of team-based care is continuity. So every time a patient comes in for a visit, they're able to see a member of their care team. Overall, this empowers our patients to collaborate with their care teams and really be involved with their health, and this just creates a healthier them. But down below, we have a picture of the people who were a part of our improvement event. So this is a mix of staff members, and also there are patients in there as well. And they did a great job of overall putting this all together. So with that said, I'll just go ahead and turn the call over to Lucia.
Great, thank you. So again, my name is Lucia Angel, and I am the Care Experience Team Lead for the Francisco Health Network Primary Care Section. And I'll be sharing a little bit about how we implemented patient advisory councils to ensure that the patient voice was part of our improvement work in improving patient experience and patient satisfaction. So I'm going to give a little bit of background. We're part of the Department of Public Health here in San Francisco, and primary care is made up of our 14 community and hospital-based clinics across the city. And over the years, over the past few years, 4 of our health centers have piloted working with patient advisory councils or working with patients in some capacity for improvement work. And through that work, we were able to see the value of the patient voice in identifying what was most important to them, and really having them partner with us to improve that. And so early last year, as our organization was moving toward a lean management system, we started identifying organizational priorities. And so our primary care leadership team identified patient experience as one of the organizational strategic priorities for our system. And so our objective through this was, can you go back? Okay. Our objective for this was to really transform our system from being a provider of last resort to being the provider of choice for our patients and family. And like Carolyn had said earlier, we used some of that research in learning that patient loyalty is really connected to satisfaction and patient experience. And we felt that we really needed to understand the gaps between what the patients expected and what the services that they were receiving. So we decided to start with patient advisory councils. Patient advisory councils, or PACs, were our patient experience or intervention. We wanted to build a space or a platform to hear and elevate the patient voice. We knew that patient advisors were vital in helping identify the areas for improvement and allowing the space for them to partner with us. And so we launched the Patient Advisory Council Collaborative in mid-2015. As part of this, we had identified staff and resources to be able to pull this off, including bringing me on board. And we wanted to communicate and collaborate with all our managers from our 14 health centers to develop a plan to establish these councils. So over a few months of communicating with them and doing some assessment work, such as using patient engagement surveys, to gauge the readiness of these teams to support the work with patients, we were able to move forward. So over the process of these pilot sites that we had worked with already, we were able to identify 3 basic skills that were necessary for success. And so this is what we focused on initially, just building the capacity of the staff and the patient advisors. So in the summer of 2015, we set off in doing Seminar 1, which was focused on group facilitation. This is mostly focused on our staff that were going to be working with our patient advisors. We knew that having staff that were able to facilitate a group and discussion well was going to be key to success. And so we hired a consultant to do a day-long group facilitation training to support our staff and patients that we had already recruited to be part of that work. A few months later, in addition to doing recruitment and starting the process of building these advisory councils, we were able to come together once again for our second seminar. And the focus of this one was really sharing and telling your story. We knew that one of the most impactful ways that our patients can help us and motivate the work is by sharing their experience and sharing their story. And we were able to partner with one of our providers who had experience in our system and working with patients to help us facilitate a storytelling workshop for our patient advisors and our staff. And that was a really important way for us to share with our patients and kind of build the work with our patient advisors and explaining what their role was in partnering with us. And then finally, the third skill that we wanted to introduce to both our staff and our patient advisors was quality improvement. We also had the opportunity to partner with an outside consultant to facilitate a full-day workshop around quality improvement. So we were able to do things like learn process mapping, PDSA cycles, standard work, things and tools that we would be using to really engage with our patients moving forward. And again, throughout this, we have the central support of myself as a patient experience lead and an additional PAC coordinator that would support the clinics in things like recruitment, patient reminders, and being able to remove any barriers that came up as we went along. So as we developed these advisory councils, we have established advisory councils at 12 of our 14 health centers. There is currently 102 patient advisors throughout our network, and they've been able to partner with us in both health center transformation and network-wide priorities, such as access, team-based care, customer service models, and then things like network communication. So some of these have been priorities that have been identified by the patients themselves, such as customer service and access, and they've helped us create standard work in these areas. And then there's other things that we have asked patient advisors to partner with us, such as communicating about our new hospital. At the health center level, they've been able to work on things that are important to the health centers themselves, understanding that there's a lot of variety in the priorities of each of the health centers. But then they've been able to work with us on things such as working with our call center, improvement work around our mammogram screening outreach specific to each of their populations of the clinic. And then things like timely-based feedback through tablets. So being able to collect information not just from the advisory council, but from other patients, and that's something that's actionable and timely. So through this process, we've learned a lot, and we feel that there's still a lot of areas for growth. So one of the things that we've learned through this is the importance of clearly defining goals and expectations. We spent a lot of time defining the roles and the expectations of the staff working with these groups, as well as the patient advisors. One of the things we didn't do as well, possibly, is setting expectations for the role of the managers or the leaders at each of the health centers. So things like setting expectations for communication between them and the groups was really important. And then dedicated resources. These are things that we've learned through the process were really important, but that just were really highlighted again, working with so many of the health centers. It was so vital to our success to have committed leadership, to have a dedicated PAC staff member from each of the health centers that we could have direct contact with and that were in constant communication with our team. And then patient incentive funds. There has been a lot of variation at each health center as to what incentives were given out. And although not absolutely necessary for success, we found that it was a really helpful tool with us, especially knowing that it might have been challenging for some of our patients to cover things such as transportation or just any other expenses that might have been incurred from them coming to partner with us. The other thing that we found that was really important was making the work visible. Sometimes it was hard to be able to understand what success meant, and being able to share that success, whether it be to share pictures, videos, just stories about how patients had partnered with us was really important, and was really important in sharing and spreading these advisory councils and patient engagement in general. And again, developing standard processes. We know that as an organization that goes through transition, and whether it be staff or patients that are partnering with us, having standard processes in place allowed for us to be able to pick up where we left off or transition work in an easy and successful manner. And then metrics for success. In order to make this work successful, we needed to show that we were being successful in different areas. And although this is still an area of growth for us, we were able to identify some process-oriented metrics initially to be able to show our progress, whether it be in number of advisors that were partnering with activities with us, or the number of advisory councils that were sustainable and active. But we feel that there's still an area of growth in terms of outcome-oriented metrics, and we'd love to hear and learn from others that are doing this work also. So with that, I will be handing it over to Dr. Singh from Riverside University Health System.
Thank you so much, Lucia. So I will be speaking about how we have used telephone visits in patient engagement. So one of the goals of our project was to increase access for patients via telephone visits. It was also to look at how we could improve patient satisfaction and to provide patients options for care other than the traditional face-to-face visits. We also wanted to capture provider indirect work as it relates to direct patient care. Many times providers were doing ad hoc telephone visits, but we weren't really able to capture all the work they were doing, and also to improve provider satisfaction. Some of the things that we were wanting to accomplish with telephone visits was to create alternative options for patients seeking care, to decrease access issues. We all have physician shortages, it seems, and we wanted to make sure we could give our patients an alternative to seeing a provider face-to-face, to decrease unnecessary emergency room visits, to decrease our hospitalization rates, and to ultimately decrease overall costs of care. So some of the key activities that we did in implementing telephone visits was we partnered with marketing to develop materials for patient education and to increase awareness of telephone visits. We also trained our scheduling center to determine which patients were appropriate for telephone visits. And we also trained our registration staff and back office on the process of telephone visits. We also trained our providers on how to utilize and document those telephone visits. So some of the challenges that we had during this process was engaging stakeholders. So, making sure our patients, administration, scheduling, registration, nursing, providers, tech support, were all engaged and involved in the process of making the telephone visit work. Patient engagement and education continue to be ongoing challenges as we have new patients come into our system, making sure they're aware of telephone visits and that they feel comfortable engaging in telephone visits with their provider. Also, the process changes with implementation of the new EMR. We moved off of one EMR onto a new EMR, and that meant whole new templates, whole new processes to fit the new EMR's way of doing telephone visits. Also, scheduling challenges with our scheduling center and training new staff as they come in on the appropriateness of telephone visits and how to schedule those. Also, we've had data challenges as we've moved to this new EMR to capture telephone visits in able to quantify how many telephone visits we're doing, as well as how many additional telephone calls we're doing, and being able to look at that data. So some achievements to date. In the 2014 to 2015 year, we had over 8,000 telephone visits. We are still in the process of collecting our 2015 to 2016 data, but I'm sure we'll have about the same, if not more. We average about 5 to 7 telephone visits per hour per provider. We've increased the number of patient touches or encounters in a very resource neutral manner by having telephone visits. Some of the lessons learned is that a lot of the patients that we see, we could have probably done a telephone visit for. So maybe up to a third to a half of all clinic visits can be substituted with a telephone visit. We also have been struggling with a lack of reimbursement as a barrier for widespread implementation, although with the changing landscape of reimbursement, we're hoping that, that won't continue to be a barrier. Also, educating patients on telephone visits during a traditional face-to-face visit helps with engaging them when we do ask for them to schedule telephone visits with us, and it helps to decrease our telephone visit no-show rates. Also, as a very practical thing, the importance of confirming a reliable telephone number and alternative number has been a challenge initially with our scheduling center, as our patients may be using cell phones or running out of phone minutes, or perhaps utilizing somebody else's telephone. We've had challenges with reaching our patients after scheduling a telephone visit, and we've learned that it's very important to confirm a reliable telephone number as well as an alternative number in case the first number is not available. So with that, I'd like to turn it back over to Carolyn Wang Kong for questions and answers. Great, thank you. So I just want to say thank you to all of our speakers, to Mia, Lucia, and Dr. Singh for sharing your insights. We are going to open it up now for questions, and so by way of reminder, if you'd like to ask a question, please go ahead and type it in the question window on your screen. Unless specified, we'll go ahead and distribute the questions to the most appropriate speaker to answer verbally. So go ahead and do that. We have been tracking the questions that we've been receiving so far. I'd like to start us off on the first question, which will be to Giovanna. Okay, so Giovanna, given the results of the recent election, how do you think the proposed changes to the Affordable Care Act might affect the reforms that are already underway around healthcare payment and new delivery models?
Great, thank you. I think the short answer here is that we really don't know yet. As I think you all have kind of gathered, there is not a lot of information yet about the President-elect's healthcare plan. It did not have a lot of specifics, so it's hard to know right now what approach he will take. We have some indications based on some of the Republican proposals that were introduced earlier this year. With those proposals, there may be efforts to implement different funding mechanisms for Medicaid in the form of block grants, for example, or per capita caps. That would potentially have an impact on federal Medicaid funding that the states currently receive, and so it may lead to a reduction in the funding that we receive. Certainly any changes to the ACA could have implications for the work that we do in Medicaid around payment reform, around delivery system transformation, around enrollment and coverage. But the answer at the end of the day is we really just don't have enough information right now to know what impact it could have. But we do know that regardless of what happens over the next couple of months, our progress and our movement towards value-based care and our movement towards making care more efficient and making care more outcomes-based and focusing on the health of our patients as part of all of these delivery system transformation efforts, and aligning healthcare financing with improvements in healthcare and quality are certainly the path that we need to continue to take regardless of what comes before us, because value-based care, in itself will make an argument for efficient use of financing. So that's the short answer.
Great, thank you. We have a second question that I believe is for Nia and the San Mateo team. So Nia, can you tell us if there were common staff objections or resistance when you started to shift from being really physician-centered to being more patient-centered? And if so, how did you handle that?
Yeah, of course. I'm working with Melissa Rombao. She's the operations strategist here at San Mateo, so I'm just going to go ahead and let her answer this question. I know she'll further answer it a little better than I can. So Melissa?
Sure. This is Melissa Rombao from the Office of Managed Care at San Mateo Medical Center. It's not that we didn't shift from the patient. I think our staff is very committed to the patient, and it always has been. They're just kind of working in a structure that is not patient-centered. And so in terms of objections, they're mostly around changing the way that the work is structured. So there's a lot of, we don't think it's broken, so why are we fixing it? Or I don't know, that's not my job. Or I don't know how to do that right now, so I'm not going to do that at all. And I can't do that because it's not in my scope. So those are, challenges that we anticipated and that we're working through. A lot of it has been remedied by training. Training is key, so making staff feel that they're prepared to do the roles and responsibilities that we're asking to do if they haven't been done before. And also presenting data to show why we're doing this, so such as quality outcomes, such as patient experience, to really get people on board.
Great, thank you. Thanks. So our third question is a bit broader, so I'm gonna open it to all three of our speakers. The question is, have any of your teams identified effective strategies to engage patients in a way that positively affects show rates? So Nia or Dr. Sang, I know with the telephone visits, that's been effective in improving show rates of a different kind. Perhaps you can speak to that part.
Sure. So for show rates, I think, going back to the team-based care model, it really helps when our nursing staff outreaches to our patients in advance to remind them, hey, don't forget, we have a phone visit with you next week, to follow up from this visit. Or, if we know that this patient may have had transportation issues in the past, our staff will reach out to the patient in advance to make sure that they are on track for a face-to-face visit. And I think that's actually a huge thing for our patients to feel like they're being taken care of well by our staff, and that our staff is engaging with them in a way where, we're showing that we care that they come to the visit, or that they show up to the visit, whether it's a telephone visit or a face-to-face visit. And I think our team-based care has really made a difference with that aspect.
And I'm wondering also, Lucia, with the patient advisory councils that you all have been working on, have you talked about kind of show rates with that group and potentially leveraging ideas from your advisors on that as well?
Yeah, so access had been identified by both our organizational leadership and our patient advisors as something that was really important for our patients in terms of satisfaction and just quality care. And show rate is definitely a part of that, being able to, not waste visits. And so one of the things that we've been working on is trying to improve our show rate for our primary care visits. And we did a rapid improvement event, so kind of a improvement workshop where we invited some of our patients, and they helped us develop our standard work around robust reminder calls. So when we were doing reminder calls, not just calling a patient and being, I have an appointment, you have an appointment tomorrow, hope to see you there, but really having developed kind of a script or a set of series of questions that would engage patients when you're able to reach them on the phone. So our patient advisors were definitely a part of that. The other thing that we're also looking at is kind of related to team-based care also, is looking at the role of the rest of our care team and not just our PCPs, so nurses or pharmacists, and being able to reduce no-shows for those folks. And one of the things that has come out from the conversations with our patient advisors has really been the lack of understanding around, who those people in the team are and what their roles are, and the importance of those people on the team and how they relate to taking care of them. And so it's not fully developed yet, but we're continuing to work with our patient advisors in how do we communicate the team to our patients, and how we talk about the team member roles, so that we can increase access by taking maybe visits that are not necessarily required with our providers or PCPs, but can be done with RNs or pharmacists.
That's great. That's great. And Nia, Melissa, anything you all would add from the San Mateo experience on this question around show rate?
Yeah, the other thing that I actually was discussing with Melissa, this is Norris Larkin, PCMH manager, is the fact that when a member of the care team outreaches to the patient and talk to the patient really identifies with that member of the care team, and it's a more personalized encounter, if you will. And the other thing is that when patients know each member of the care team and they can identify with the member of the care team, they're more likely to come to their appointment because they see each other as partners in care. And with having so many different people assigned to the team, there's a lot more opportunity for the patients to have their needs met, not solely by the provider, but perhaps by the health coach or the diabetic educator, pharmacist, and in that way giving more access to the patient and helping the patient to actually attend their appointment.
Great. Thank you. Our next questions, we actually have a few for Dr. Sang around really the logistical pieces of phone-based visits. So I'll run through them and then have you respond. So the first is, does your organization assign a specific group of physicians to make the calls, to do the phone visits? And how do you manage this given physician shortages? The last piece of it is, how long and how many phone visits are usually scheduled into a physician's template?
Thanks. Those are great questions. Right now, all of our clinicians are given an hour to do phone visits daily. These phone visits can be staggered throughout the day. So the provider, chooses if they want to do it at the top of their clinic time at 8 a.m. So then they'll have an 8 to 9, or a 1 to 2, or a 4 to 5. So, we allow the providers to choose based on, their workflow and their work styles, what works best for them. We just ask them to not all do it at 8 to 9 so that we can kind of spread out the availability of phone visits. After that, what we've done is we've built out our templates for phone visits. Right now, they're in 10-minute increments. So, for example, if one of my providers is doing a phone visit from 8 to 9, they'll have an 8, 8:10, 8:20, 8:30, 8:40, 8:50 slot. And we advise our patients that we give a 20-minute grace period in order for providers who might be running a little bit long from the last telephone visit because they're using a translator or had additional questions or things. But we find that 10 minutes is actually very adequate for the amount of time needed for a telephone visit. Let me see, what was the other question that we had there? I think logistically, that having those 6 phone visits scheduled, usually what we do is we also give the opportunity for the care teams to control currently 3 of the 6 visits so that they can schedule phone visits with their patients. And we have 3 that we give to the scheduling center to open up to whoever may need a visit with a provider. So we have both those options, so 3 given to the care team, 3 given to scheduling center, and that seems to be working very well. As patients call the care teams and want to access their provider, they're allowed, almost immediate, if not next day, access to the provider for questions, concerns, medical advice on different things, and that's been working very, very well for us.
It seems like a great balance for flexibility there. We had received one more sort of follow-up question on the theme of phone visits, and that is, so Dr. Singh, how are these visits reimbursed?
That is a great question. So that was part of, that's one of the things that we as an organization decided was an added value for our patients and for the providers. So right now, the reimbursements, we are putting in the codes, but we're not actively being reimbursed. We're hoping, as we move towards value-based care, that some of this will change. But there are telephone visit CPT codes that are published that we do use, and I'd be happy to share it with the whoever's interested. But we do not currently bill for those professional fees. I believe one of the things that we have looked at, as we're looking at our waiver programs, we participate in Prime, we're participating in the global payments, and within global payment there is the opportunity for reimbursement of telephone visits.
Great. We've got one more question that I will direct to Lucia, since it's around patient advisors. How do you handle language diversity and other accessibility issues when you're bringing together your patient advisors?
Yeah, so we actually have a few clinics that have decided to develop their advisory councils in the language that is most appropriate for their population. So although most of our advisory councils are in English, we actually have 2 advisory councils in Spanish that are run in Spanish, and then 1 in Cantonese. So those are, just based on the language of the clinic, the dominant language of the clinic. In addition to that, when we try to bring patient advisors together, for example, tomorrow we're having a large end-of-the-year retreat, kind of reflecting on the success of the year and making plans for 2017. We have a couple of staff that are bilingual that will be doing some translation in the moment with those groups. So although the majority of the event will be in English, we will incorporate Spanish and Cantonese in that, both up front, and we've translated the material. So just having staff that have the ability to do translation of material and then do translation of the content throughout the day. So it's definitely challenging. It's something that we continue to grow in, but we think that in order to be truly representative and inclusive of our patients, we have to do that. So we're trying our best to do it in whatever way we can.
Great, great. Thank you for that. Thanks, everyone, for all the great questions. We are at our time limit, and so there were a few questions that we did receive that we weren't able to get to. I'll mention in a couple minutes, we'll send those responses out with the follow-up materials. But before we sign off, I wanted to just leave the group with a few final thoughts that we've learned from today that the research really does show that a patient-centered approach has a positive impact on health outcomes, on adherence, and patient satisfaction. As you've heard from all the presenters, these strategies can not only improve the patient's overall care experience and outcomes, but they're also very necessary in terms of being a platform for implementing these other care transformation efforts. So because there are many different approaches to engagement, our foundation has been conducting research on how we can consistently and reliably measure the effectiveness of patient engagement initiatives across these various care settings. You've heard Lucia also alluded to this in her presentation around outcome metrics. We believe that by having this ability to measure, we'll be able to give more important insights on what you might want to do to change existing programs, what items to consider when you're designing new initiatives. So some of the questions that we've been thinking about are there existing measurement tools that can be adapted for our specific patient populations in terms of measuring engagement? Should we leverage our knowledge and previous research to develop a new measurement tool or index? So these are just some of the exciting questions that we're considering, and when time comes, we'd want to work with all of you to make these tools available for everyone's benefit. I want to say thank you to everyone for joining us today and for your interest in this topic around advancing patient engagement in the safety net. A recording and the slides from today's presentation, as well as I mentioned, all the answers to any questions we weren't able to get to, as well as many other resources around engagement, will be available on Blue Shield of California's website, which is blueshieldcaliforniafoundation.org. And then a follow-up email with details on how to access all of this information will be sent to all of the participants. So thank you again, and we'll look forward to sharing more information next time. Thank you.